Commander Pedley is the Director of the Office of Pharmacy Affairs in the Health Resources and Services Administration. Our office administers the 340B drug pricing program through which outpatient clinics and hospitals purchase approximately $6 billion annually in discounted drugs, or a little over 2% of the U.S. pharmaceutical marketplace. The mission of OPA is to increase access to clinically and cost-effective pharmacy services. Commander Pedley is a commissioned officer in the United States Public Health Services. Please welcome Commander Pedley.
Thank you for having me this morning. I'm really happy to be here and to really give you some highlights of what's going on in the 340B program. I will say that while the attention on the program the last couple years has been very great, from GAO to the Hill to really all of the stakeholders, I do just want to say that I believe that the program is in a much better place, regardless of how we got there and how painful it may have been the last few years. We all want to move the program really into a more compliant manner that has more integrity than it ever has, and that is our main goal. So I'll just start with that. I do just really want to have a general dialogue with you. I have slides here, and I'll go through the slides, but I really want to open it up for questions after we go through some of the updates going on in the program. So in terms of our program integrity strategy that we are working on, and this is throughout everything that we are doing, we work on both the initial certification process, so both manufacturers and covered entities that enroll in the program, and that process for ensuring that they are meeting all eligibility requirements before they participate in the program. Our on-site program audit process and annual recertification all have different roles to play in the integrity process. Again, that initial certification to ensure eligibility from the start, the on-site program audits to go in and really test and see what's happening on site, to annual recertification where we can reach each and every single covered entity that participates in the program. And we focus on the three main areas of the program, the first being eligibility, to ensure that entities continue to be eligible, including the GPO prohibition, which I'll go over a little bit, ensuring against diversion of drugs to ineligible patients, and to avoid duplicate discounts. A little bit about initial certification. I'll go through these three strategies. I know that many of you as manufacturers may not be a part of this process, but I think it's important for you to understand how entities get into the 340B program and ultimately are listed on our database. They do go through a process that is online, which is newer in the last few years. They go through a rigorous process through HRSA and my office to ensure that they meet all those requirements. There's 22 different eligible entity types, and they each have very unique circumstances for which they can be eligible for this program. So we make sure that they meet those requirements before we enroll them. And of course, then they wait the decision from us, and then they are listed on our 340B database, which is the source of truth for which entities are able to purchase 340B drugs. I will say that an entity must be listed on our database to purchase or use 340B drugs for their patients. All sites must be listed, meaning any hospital outpatient clinics or any sub-sites of the grantees all must be listed on our database. This is newer in the last few years for us to improve transparency of who out there is actually participating in the program, again, including all those sub-sites. And we've done a really big push through recertification to ensure all locations are listed on the database. We also ensure that the information on the exclusion file is up to date to assist states and manufacturers, at least as a first test around duplicate discounts. We recognize that the exclusion file does not solve every problem around duplicate discounts, but it's the starting point that manufacturers and states should use to then dive deeper to understand what's going on in each entity in terms of Medicaid and whether they're carving in or carving out. Just a reminder about covered entity requirements. It is an entity's responsibility to inform HRSA immediately of any changes in eligibility. And if they stop purchasing at the time they know they have become ineligible for this program. While terminations have always been on a quarterly basis, entities are still supposed to stop purchasing when they stop becoming eligible for our program. And we have instituted new in the last couple quarters. We do separately push notify and email to manufacturers if we have evidence from an entity that they purchased beyond their eligible date, so that manufacturers have that information. They are then urged to work with manufacturers regarding any repayment if they did make purchases after the time they were not eligible to do so. That's something new that we have built into our processes, and we plan to push notify the manufacturers every quarter of the list of entities that do purchase after they became ineligible. Also important to remember that entities are supposed to report to OPA noncompliance. I will say that we have an increase in self-disclosures, and we work with each and every entity to ensure what they disclose is accurate and that they have appropriately validated any type of information in terms of what the manufacturers need in terms of any recoupment efforts. We do plan to institute a process where we will be posting some information about self-disclosure, so stay tuned for that. My guess is that as manufacturers, you're seeing an increase in checks maybe from entities or correspondence from them that they may owe money. This is probably due to the self-disclosure process. Something else around our database in terms of transparency, over the first 20 years of this program, for some reason, there have been many pharmacies in our database that have obtained 340B IDs. Pharmacies are not eligible for our program. The clinics and hospitals as eligible entities are. So we are going through a process where we are cleaning up the database to ensure pharmacies do not have IDs. They should either be a ship to, or if they are a contract pharmacy, they should be listed as such. But only clinics and hospital sites that are providing care to patients should have a 340B ID. So that's another effort that we are undergoing. And again, I had already mentioned about that all sites actually need to register and be listed on our database. A little bit about contract pharmacies. We have a new electronic process in the last few quarters that we believe is also improving the way that contract pharmacies register for the program to ensure that the covered entities are aware of these relationships. So what's happening now is that a contract pharmacy can register its pharmacy, but the authorizing official of that covered entity will receive an email that says, this contract pharmacy is registering under your covered entity name. Are you aware of it, and do you approve it, before we sign off on it to ensure that everyone is on the same page. If they reject or do not respond, we do not register that contract pharmacy. That has occurred the last few quarters, and we've had the pharmacies push back on us, but if those AOs reject or do not respond, we do not register that contract pharmacy. So that's a new process we have in place to help validate this information. A little bit about our ongoing audit process. You can see the areas here that we focus on. We do have a new program integrity page on our website where we outline the process and information regarding our audits. We do have a process by which we select the audits. We use both a risk-based strategy and a target strategy. The risk-based audits, we have built in risk-based criteria, and then the entities are randomly selected based on that criteria. For example, volume of purchases, length in the program, the number of contract pharmacy arrangements that they have, because we really want to go after those sites that we believe are at higher risk under this program based on our experience with what we are finding, and we continue to refine those criteria over time. We also select audits based on our target audit criteria, whereby if we receive, for example, an allegation or other types of information where we actually need to go on site to really understand what is occurring, we can go in and target an entity and look at something very specifically regarding that 340B site. I'll also state that you'll see the number 51 here. But the more important number is the number of sites that encompasses. So when we go on site to a parent covered entity, so they are the main 340B ID, we do a sampling of their sub-sites and their contract pharmacies to take a look at everything that's going on within that entity and all of its sub-sites or contract pharmacy arrangements. So in fiscal year 12, we conducted 51 on-site audits that encompassed over 450 sub-sites and over 400 contract pharmacies. The results are preliminary until they were finalized by HRSA. We will then post on our website once the entity agrees with our final audit findings, and then we will update the information accordingly. We currently have 42 audits that the entity has agreed with the final findings, if there were findings, and their corrective action plan is in place, and I'll talk a little bit about that process on the next slide. But just to give you some statistics on the 42 audits to date, 62% of the audits posted were hospitals versus non-hospitals or our grantees. 43% of the 42 audits had no findings. 26% had diversion, 33% had duplicate discounts, and 31% had database findings. And again, those percentages include the fact that some sites had multiple findings, but just to give you a feel for where things are. Not real surprising to us that some of that was on the higher side because of the risk-based strategy that we have in place, but that's where we are to date. And you will see these 42, their corrective action plans, many of them are still pending at this point. So how it works is we go in, we sample, we find an incidence, for example, of diversion. You'll see on our website that there was diversion, but that could be a prevalence from anywhere from one incidence of diversion we found in the sample to many findings of diversion, but it's then upon the covered entity through their corrective action plan to really go in and look at the scope of the problem, define it, and then validate the information so that we can better understand how they plan to repay manufacturers. So that's the fiscal 12, and the fiscal 13, I do have updated numbers here as of today actually. We have completed 82 on-site audits encompassing over 670 sub-sites and over 1,700 contract pharmacy locations. There's additional 12 sites that have been engaged, but the on-site portions are in process to total 94 for fiscal year 13 to date. So the number has increased from last year. I talked a little bit already about the audit results, but just so you understand the process, an entity has 2 chances at what we call notice and hearing, which is required by the statute. Our regional auditors go out, they conduct the audit, they submit their reports to HRSA. We then provide the preliminary findings, if any, to a covered entity. They have 30 days to agree or disagree with those findings. We then turn that into a final report. We may reverse our decision based on any documentation that an entity may provide to us. We then send out the final report to the entity. They have another 30 days to agree or disagree with that. If they agree, they have then 60 days to submit their corrective action plan, but we do have to approve that plan before they implement it. So we are in a stage where the remaining audits are either are back and forth with us on their corrective action plan, or they are in some phase of notice and hearing. So you'll see that we still have a number of audits that need to be completed in 12, but they are all in the notice and hearing phases, and we are really close to being able to complete the remaining audits. So this is the process that is used. We do plan, once the fiscal year 12 audits are complete, to create tools and resources based on the common findings. And surprisingly, you know, we have been able to find through our sample size some issues that are very common to all covered entities. And while many may argue that, you know, how are we even finding things wrong when the guidances may be very loosely interpreted, but we are finding things that are very clear-cut that we are able to rule on. And we're going to help all the other covered entities implement strategies to ensure that they are in compliance based on what we found in the other audits. So be looking for some tools and resources after the fiscal year 12 audits based on the lessons learned. So HRSA also has the authority to audit manufacturers and wholesalers, and we do continue to receive allegations against manufacturers regarding their compliance with the program. So it is important that you all recognize that you have a role to play as well in compliance. It's not just the covered entities. And we have been working through a few issues with manufacturers to date. Again, we review every allegation. We follow up with the manufacturer to understand what's going on. Some of those things can be resolved. Some we're finding may not be able to be resolved. And we are in the process of looking at a specific situation that may result in an audit by HRSA to take a look at what's going on. So again, just want to state here that, you know, Ed mentioned our whole balancing act. I think it's important to recognize right now, because a lot of information coming out of our office may seem like it's very covered entity heavy because of the audits and everything else going on, but we also do have a very close eye on what's occurring with the manufacturers and their compliance. So it's important that you understand your role in this program. Annual recertification. Again, as I mentioned, this is an opportunity for us to reach each and every covered entity beyond what we can reach through our audit process. It is required by statute. Entities are required to ensure their information is accurate and up to date on the website, and they also have to attest to their compliance in the program, which has been really interesting for us to see how self-disclosures have increased due to the fact that an entity does have to attest to the fact that they have to submit to OPA any breaches of compliance. We are currently in the process of recertifying hospitals in this program. It'll be their second time to recertify. I am happy to say that last spring we have recertified every entity at least once, and now all the entities are on an annual cycle to ensure that information. I think that I believe that our database is probably cleaner than it ever has been through this process to really ensure that the sites that are listed are actually participating in this program. We found a lot that some entities just listed because they were told to sign up, but they never used the program. Well, while that's fine, we want to make sure the database actually is capturing those that are using it. And not to say, too, we use the database to run all of our random sampling for audits and that type of information. So it's important that those sites are listed are actually participating. So as I mentioned, the hospitals are undergoing recertification currently. Their deadline is Friday. As opposed to last year, because it was our first year with hospitals, we did allow extensions and for people to take time to go through this process. That will not be the case this year, and we have not allowed extensions for any of the other covered entity types this year, and we will not for hospitals either. What that means is if we don't hear from a hospital by Friday and we are making multiple attempts, we're working with a lot of the hospital advocacy groups to ensure that the sites that have not yet recertified, they do so, or they will be terminated from the program on Friday. So I would keep a close eye on what happens and how many terminations result from this recertification process. I will say it's going a lot smoother than it did last year. We learned a lot last year through the process, especially going through the hospitals, but we are excited that they will be completed with their process on Friday. Some additional items, and a lot of these we've been doing for years, but just as a reminder, some of the other program integrity activities that are going on in the office, including quarterly calculation of the ceiling prices, the maintenance of the Medicaid exclusion file, again, reviewing all allegations against either an entity or a manufacturer and following up. I don't have listed here self-disclosures. That's another huge area that's increasing in the office and dealing with self-disclosures. Providing technical assistance, 340B University, peer-to-peer webinars, FAQs, and policy releases. And I'll go through some of these, but we really have increased our efforts around education and how important that is so that entities, when they sign up for this program, it's no longer, I want to sign up to receive good price on my drugs. It's about, I want to understand before I go into this what it costs to comply, what this program means to me before I sign up. Do your cost benefit. This program, just because a site is listed in the law, it's not meant for everyone to participate. If it costs your hospital more, obviously, than what you're going to save, it's something that you should not consider doing. So we really are creating the tools and resources to help the entities do this analysis before they enter into the program. And through our contract with Apexis and the peer-to-peer program that we run, we've really increased our efforts around education, which I'll talk a little more about. You'll see here development of regulations. So this is a big area for us as we move historically a program of guidelines, FAQs, to one of regulations. And as you're probably well aware, and you'll see in my slides, we have published the first rule in the 340B program in July on orphan drugs. And we do plan to issue an NPRM on the 340B program in June 2014 that will cover all the foundational elements of the program. It will not include some of the items that are new to ACA that we were not funded to do, but it will include all the base elements, including patient definition, contract pharmacies, et cetera. I will say that this has been a really great task for us and one that we have wanted to really put on a fast track because we know how important it is to the marketplace to get this NPRM out there. I will also say that, we have now 20 years of experience in this program of what's working and what's not working in terms of our guidance. We meet with a lot of stakeholders to understand really what's happening on the ground that we have used to really inform this process that I believe is really a great direction moving forward. So stay tuned for the NPRM, and we look forward to everyone commenting so that we can work to improve it based on where you see the different policy decisions being made. And we're always continuing to make database enhancements. Hopefully you're seeing the results of some of that. We're really trying to invest in that area, both to improve the transparency and validity of the information on the database so it is usable for everyone. So I can't go without saying that while our efforts have been great in the last few years to get us where we are, we've done all of, we've done all that work with no new money. We've done all of that work because we've reprioritized and looked at how we do things. But we're only going to be able to take it so far. And we want to do more and build off of what we've been able to do in the last few years. And the only way we're going to be able to do that is if we can have a user fee. The user fee is again in the President's budget. It has been for the last few years. The covered entities would pay a fee on top of their drug price. That would be, so the entities pay it, and then it would go into a Know Your account that HRSA could then use to operate the 340B program. While the manufacturers would not have a role in that collection process, the manufacturers would have to report to us sales data so that we could ensure that the entities are paying the appropriate amounts. So this is one that I do want to say that in order for us to take our efforts further, we are not going to be able to do so unless we are resourced appropriately. Here's our latest policy releases. As you're aware, we started the policy releases back in 2011 to really help clarify some of the issues going on in the market that we felt the need to go out and clarify. More recently, that got a lot of buzz, the GPO prohibition. Again, this is one where we do believe was just a clarification as we conducted audits. However, in the last year, we quickly understood that entities were not appropriately interpreting what we believe to be the appropriate way to apply the GPO prohibition. So we did clarify that in February. Because we knew the market was where it was, we provided entities an opportunity to get into compliance by August 7th or terminate themselves from the program. So we are now obviously past that date, and we would expect every entity that is participating that is under the GPO prohibition to ensure they are appropriately implementing it, or they will be found in violation of the program. The GPO prohibition is an eligibility requirement under the program, so there are additional sanctions here if they are found in violation, which would be termination from the program. So manufacturers have always had the authority to audit covered entities as well, and it wasn't until the last year and a half or so that manufacturers have decided to move forward to audit covered entities. There is guidance out there, and has been since 1994, for the process by which manufacturers should take to conduct audits of covered entities, including the need for reasonable cause to do so, and the statute limits manufacturers auditing diversion and duplicate discounts. You do have to submit a work plan to HRSA prior to engaging an entity, in addition to working it out in good faith prior to. We then have 15 days to turn those around, give feedback for then the manufacturer to proceed with their audit. So to date, and this is since the beginning of the program, we have received 8 work plans. 7 are proceeding and moving forward with their audits. 4 have been finalized and submitted to HRSA, and we are in the process of working with each of those entities now to understand the scope of issues. As you can imagine, the manufacturer audits are very focused on their product or products. It is then HRSA's role to understand how the findings of that manufacturer audit affect entire compliance for that entity for all of its drugs. So we are in the process of working with those 4 entities to understand next steps for them. And I think this is an area, and you hear this a lot now in the conferences, how important it is that manufacturers are sharing lessons learned in this area. It's new for them, it's new for the entities to really gain some best practices. I do commend the manufacturers for moving forward in this area. We would like to see more of it. I do know from talking with a lot of manufacturers that many of the processes that start out in good faith are able to be resolved prior to an audit, which is good to hear and how the process should work. But we also understand that there are going to be circumstances where it is necessary for a manufacturer to go in and have their independent auditor audit these covered entities. Orphan drug final rule. So talking about probably ticking off the room. I will say that again, our first rule in the program, this is an item that was added under ACA, that the entity types you see listed are exempt from purchasing orphan drugs. It's very clear that it was under Section 526, which is what is stated in the law. We published an NPRM in May 2011 and the final on July 23rd with an implementation date of October 1, which you all know is coming very quickly. The purpose of the rule from HRSA's standpoint was obviously to provide clarity and to ensure that to maintain the savings of the new eligible entities that were added to the ACA, but to also protect the financial interest of orphan drug manufacturers. The stance that we took in the rule, that HHS took, is consistent with the FDA's interpretation of how they oversee the Federal Food, Drug, and Cosmetic Act. So what orphan drugs are excluded? So the orphan drugs, when used for the rare disease for which they are designated, do not qualify for 340B if they're one of the entity types listed. We will publish on our website, which we did on September 1st, the list of drugs to be excluded. We started with the FDA's Orphan website and the list that they have. We have posted then the drugs that have designations that are applicable to our program. If anyone has seen the website, you will see that we have clearly noted that there's going to be some work to do on this list. It came to our attention through some manufacturers that clearly the sponsor that received the designation may not be the current sponsor manufacturing the product, and how is an entity going to know which product to exempt from the 340B program? So we are in the process of improving that list and trying to tie NDCs to each individual product that should be exempt. I do believe that this is likely going to need to be a partnership with manufacturers that we will have to undergo. So At this point, I do ask for patience and understanding that this is a work in progress and that we will need to work with you all to improve this list to ensure the entities are excluding the most appropriate, the drugs that the rule excludes. So we will post the list the first day of the month prior to the end of the quarter that will apply for the following quarter. So we published on 9/1. The drugs on that list will be exempt for the quarter 10/1 through December 31, and we will do that every quarter. It did change the definition of covered outpatient drug, so when these drugs are used for the rare disease or condition for which they are designated, they are not considered a covered outpatient drug, and that's important for reasons more specifically to the GPO prohibition, but an important point to note. So entities are required through the rule to inform HRSA whether they will choose to comply with the rule, opt-in, meaning they have the ability to track by indication and ensure the appropriate drugs are excluded, or whether they will opt out and purchase all orphan drugs outside of the 340B program regardless of their designation or indication. We, through the process of annual recertification, are collecting this information from each and every hospital that is affected. So we plan to post by the 15th of this month. We will freeze the list at a point in time on the 15th that will apply then for the following quarter for whether someone opts in or opts out. Entities can only change on a quarterly basis, but you will see in our database already today, if you go into a specific hospital that's affected, you can see whether they have chosen to opt in or opt out. But the list that we freeze at a point in time should be the list that is used for the following quarter. I do have some statistics of where we are so far. We do not have everyone responding as of yet, but we do have 61% of the hospitals affected have chosen to opt in, and 39% have chosen to opt out. So I just wanted to give you those statistics. They are changing every day because of the final push here at the end of research for more entities to provide this information, but that's where we are to date. This just really shows, and this was in the webinar that we had, this really just shows the flow of kind of how the decision is made about opt-in, opt-out. Probably really hard for you to read in the back of the room, but it really just states, if someone chooses to opt in, which drugs are covered, not covered. And then, of course, we have the nuance of the freestanding cancer hospitals, which there are only 2 in the program. So we will be working with them, but they do have the additional nuance of the GPO prohibition. So depending on their decision, opt-in, opt-out, they may or may not be able to use a GPO for those drugs, as I stated earlier, because the drugs used for the rare disease condition are not considered covered outpatient drugs, so they can use a GPO, but only if they are able to track and do so. So this could get pretty tricky for them. Records requirement, so entities, again, they're required to keep records of all of this information, and they need to be available upon HRSA's request or to a manufacturer. So this means that both HRSA and manufacturers have the authority to audit on the orphan drug exclusion. We clearly state in the rule if there is a violation of the orphan drug exclusion that it is considered diversion. It's what I state here. We are in the process of putting in place parameters in our audit protocol for which we will audit for this item. So just in closing, before I take some questions about our resources and our partners. APEXIS, the 340B contracted prime vendor program, I'm not sure how we would be doing it without them right now in terms of the call center alone. The volume that comes through that call center, which is available for free to all stakeholders, the volume is just tremendous right now, and we are able to, through APEXIS, answer all questions that are raised. We're able to assess what are the top questions, so maybe do we need to create an FAQ? Do we need to build something into the education program based on the types of questions we are receiving? I will mention as well the 340B University. Many of you probably familiar with that. Hopefully many of you have attended. Again, our push towards education is the source of truth for information. More and more, and as we do audits, unfortunately, there's a lot of consultants, vendors in this space, and they may have received information and didn't turn and validate that information and have been practicing in a certain way based on the information that they received. We are increasingly encouraging entities that they need to ensure that how they are practicing is in current compliance, and the way to do that is to contact APEXIS or OPA to understand it. It's also at a point where they should be questioning even some old guidance that they have received in the past to ensure it's how we are operating today. So APEXIS as the source of truth to be gaining this information. The other item is the HRSA's 340B peer-to-peer program, another huge education push. Years ago, we did a process where it was a one-to-one technical assistance. Now through the peer-to-peer program, it's many-to-many. We've highlighted best practice sites across the country that do monthly webinars that are able to provide education to other entities like them on how to implement the program in a compliant way. So they are not policy discussions, but they are boots on the ground. How do we put these policies into place? And that's also available to all stakeholders as well, and has been a great success and how we reach all the entities. And if sites are want to be a high-performing site and noted as such, you can see here how they can do that. And we do site visits to understand what's going on the ground to ensure that they actually are operating in a way that it's compliant with the Office of Pharmacy Affairs policies. So here's contact information, and with that, I would be happy to take any questions.
Commander Pedley, thank you very much for taking the time to speak with us. You had made two comments earlier I'd like to ask a question on. You had stated that HRSA is actively making proactive push notifications to manufacturers for sales or purchases by entities after their coverage has lapsed. And secondly, you had said during your risk-based audit approach, you would test, one of the test criteria was the volume of purchases. Given the nature of this program whereby purchases are made by thousands of disassociated entities in a decentralized fashion, my question is, where is HRSA obtaining the data to make these determinations, and how is that data being combined and analyzed?
So in terms of volume of purchases, we use and work with our prime vendor program, who has the ability to collect data on purchase volume for each and every entity and their sub-sites, and that's what we use to determine that, and we build that into the risk-based criteria.
Sorry, just one more question. I hope this one will be useful. Thank you again for coming and addressing this group. We appreciate HRSA's willingness to appear before a group of manufacturers. As you may know, and as you certainly know, the intersection between the 340B program and the Medicaid drug rebate program and our obligations in the Medicare program are many and diverse. I wonder if you might take a moment to speak about the relationship you have with the people who run the Medicaid drug rebate program at CMS. And I'll give you a specific example perhaps to react to. In the proposed rule, there is a suggestion that manufacturers really become the policemen of the 340B program by stripping the best price exemption for those drugs that are purchased outside the program. I know many of us in the manufacturer community have submitted comments suggesting that's an inappropriate way to govern the 340B program, but I wonder if you might speak to your relationship with CMS and how that works.
Absolutely. I would say that it's been one of our focuses the last few years to improve the relationship we have with the Medicaid folks, and we do have a great relationship with them currently. We are jointly discussing issue amongst our separate regulations that are occurring. I'm very aware of the issue that you've mentioned, and we've talked to CMS about it a lot. In general, again, I'll say that we do have a great relationship. We talk through issues. More so it has been on the duplicate discount side and what's going on in Medicaid managed care and what's coming out there. But we have increasingly worked with them on some of the best price issues. Increasingly as well issues around if manufacturers are receiving refunds, what happens with best price and pricing reporting to them. So I believe we have a great relationship with them. I never hesitate to pick up the phone and talk with them. They do the same. I would say we have a call every few weeks on issues that are arising. So we do have a good relationship. We're aware of each other's issues. Doesn't mean it's always easy, though, because our programs have very different focuses, audiences. So, at times we get to a point where, we may disagree with each other on something, but we always agree to talk through it and understand how it's going to impact each other's programs.
Thank you.
You're welcome.